Everyone, it gives me great pleasure today to introduce Dr. Anu Willey, who is a consultant pathologist at Nottingham and at Lincoln. She does dermatopathology at Lincoln, but today she's talking on renal biopsies. She's a colleague of my friend Sindhu at Nottingham. Renal biopsies, we have had a talk probably about a month ago on renal biopsies, but I think that it's really good to have exposure to this area. It's a complex area. People don't get an awful lot of education in it. Anu has got a very extensive teaching portfolio, is very keen on teaching trainees and has an international background as well. Because we are in a webinar format, if people want to make a comment or just raise your hand, and Emily, who's providing the admin support, will unmute you. Otherwise, we'll take questions at the end with a Q&A. So without further ado, I'll pass you over to Anu. Thank you very much.
Thank you, Richard, for this very kind introduction. So, as I don't know what topic you were taught last time, but kidney diseases are kidney is a very wide area, and it's best to concentrate on one particular area to sort of give to the trainees a more comprehensive approach in that area. So, a lot of times when I've been asked to give talks, we sort of talk about mainly glomerular pathology because that is the area where people concentrate on. But the reality is that glomerular pathology, although it forms a major part of our diagnosis, we tend to sort of ignore the tubules and interstitium and the tubulointerstitial diseases, which are also a significant part of kidney pathology. So I thought today, as a sort of a slight change to just talking about glomerular pathology at the time, I will concentrate on the tubulointerstitial diseases and how they actually make part of our diagnostic spectrum. So I'm not going to spend a lot of time on certain things because I think a lot of you will be knowing about certain sort of common diseases. Acute pyelonephritis is one of the sort of common diagnoses, but fortunately for us, it is becoming a lot rarer. And most of the times, clinicians make a diagnosis clinically of this condition, so we do not tend to get biopsy of this condition very often. But if you do actually have to look back and see what you see in it, you would see intratubular plugs of neutrophils, and you would see an interstitial inflammatory infiltrate with lots of neutrophils, and associated with it, whenever something involves the tubules, you also get a sort of component of acute tubular injury. So just to show you here, this is a high power magnification of the tubules where the tubular epithelial cells look quite flattened and the tubular lumen are all filled with degenerating neutrophils. Along with that, inevitably, not just in the tubular lumen, you will also get inflammation, which will be sprinkling out into the interstitium. But unlike tubulointerstitial nephritis, where the inflammation is predominantly in this interstitium, in pyelonephritis, the inflammation will be mainly within the tubular lumen. One of the sort of complications which you get with acute pyelonephritis is renal papillary necrosis. Again, relatively rare as the treatments are pretty good nowadays and you don't tend to see these sort of major devastating renal complications. So going on to something which we see very often in our kidney biopsies, whether they are native or whether they are transplant, is something which particularly is not taught very well, is acute tubular injury. So what is acute tubular injury? It is actually a reversible destruction of the tubular epithelial cells, which then in turn leads to an acute suppression of renal function. And the important bit to remember is that the amount of changes you're seeing within the tubular epithelial cells do not always correlate to the renal function. So you could see very minor changes as like flattening of the tubular epithelial cells, but the patient might be in acute renal failure. So it doesn't always correlate very well. The two main areas, or the two main types of acute tubular injury, or ATN, what we call, is ischemic, which is the acute vasomotor nephropathy, and then we've got the nephrotoxic type. So ischemic is the one which luckily we see more often, and that is mainly due to anything which is causing, an inadequate amount of blood flow, leading to hypotension, and then causing changes within the kidney. It is basically because the ischemia causes vasoconstriction, and then that leads to reduced GFR and then oliguria. So this is the one we see commonly in practice. But the one to remember is something which we need sometimes from the clinicians, a detailed history, is the nephrotoxic pattern of acute tubular injury, which can be related to quite a few agents now. Obviously, the ones which are the older ones are like carbon tetrachloride, cisplatin, ethylene glycol, which I will go into a little bit more detail because you see oxalosis with them. Quite a few drugs like antibiotics, obviously products of transfusion, I mean, hemoglobin, obviously not in this part of the world, but in other parts of the world, malaria, poisoning due to lead, poisoning due to anything related to paraproteinemia, like light chain proximal tubulopathy, light chain cast nephropathy, which again, I will go into a little bit of detail a little bit later. Other things like mercury, other drugs like methotrexate, and another important one is myoglobin, which again is something if as a pathologist we don't think about, we can miss it. And myoglobin is, again, I'm going to show you some pictures in the past. Myoglobin is very toxic to the tubular epithelial cells and causes quite severe acute tubular injury. Along with that, there are certain other things like radiograph contrast agents and other things which can cause proximal damage to the proximal convoluted tubules. Now, this is just a list of some of them. It's not an entirely exhaustive list, but just to give an idea of how many things can cause or how many agents are around there which can cause quite severe damage to the tubular epithelial cells. So if we go with the ATN, there are changes which occur in the early stages where you will see some swelling of the tubular epithelial cells, then which will later lead to tubular epithelial necrosis. So the epithelial cell will start getting necrotic and then desquamate and then fall into the tubular lumen. You can see apoptosis and then debris within the tubular epithelial cells. Now, what happens is that all this degenerate debris can then form a cast with the TAM Horsfall protein, which is a normal urinary glycoprotein secreted in the from the cells. Along with the acute tubular injury in the tubular epithelium, you will also see quite significant interstitial edema. So the tubular lumen and the tubular epithelials, which are actually tubes are next to each other, they won't be lying next to each other. They will get separated by edema. In the later stages, when it is resolving, because most of the times ATN is self-resolving. If you take away the agent which is causing the damage, the tubular injury resolves itself. So there is epithelial regeneration, and then you will start seeing mitosis and prominent nuclei and big nucleoli in those tubular epithelial cells. In the nephrotoxic type of ATN, obviously you will see some of these features, but the only other difference is that there will be quite marked extensive necrosis of the tubular cells rather than just scattered necrosis of the tubular epithelial cells. Just to show you some pictures of acute tubular injury, if you are not thinking about it, you will not pick it up. So this is one where you've got some changes ranging from some coarse vacuolation of the tubular epithelial cells right here. Then you've got interstitial edema because the tubules are not lying next to each other. There is flattening of the tubular lining, and then you can actually see start some debris accumulating within the tubular epithelial cells or the lumen. Again, in this one, there is some dilatation of the tubules here, but if you can see that there is flattening of the tubular epithelial cells along with debris forming within some of the dilated tubular lumen. This is an early one where you it hasn't managed to form those the debris, but you can start seeing, you see only early coarse vacuolation of the tubular epithelial cells. Again, in this one is slightly later stage, and you can see although the tubules are, some of them are still dilated, you can see in this one that the tubular epithelial cells have started regenerating, and you actually can see a normal mitotic figure in one of the tubular epithelial cells. So that is when the tubules have started to regenerate, and it's called resolving acute tubular injury. So that is what you as a sort of a general picture of what you would see in acute tubular injury. There is acute tubular injury associated with myoglobin, which I thought I'll make a special mention about because it can be quite a sort of an important diagnosis to make if the clinician is not thinking about it and you miss the type of changes you see within the tubular epithelial cell. Obviously, the history is important, and as I've just sort of said that working with the clinicians is at a very close level is important to know whether the patient has had a road traffic accident or has developed muscle injury relating to the release of myoglobin. has had quite severe or increased muscle activity, like sometimes of severe exercise, or even has had a seizure, which can cause a release of myoglobin because of the muscles going into spasm, certain toxins, and obviously certain hereditary diseases and certain changes in the phosphate levels. So these are the ones which can cause rhabdomyolysis, some of the ones that can cause. One of the things that also we now see more is medications. And one of the medication that we come across is the intake of statins for hypercholesterolemia. Now that definitely has got a direct link to developing myoglobin injury. So what happens is that this myoglobin is then released from the muscle. It gets filtered very freely through the glomeruli and then concentrates within the tubules. Within the tubules, it then joins or forms a cast with the TAM phosphor protein or the uromodulin, and then blocks the tubules completely sometimes. And these particular casts are extremely toxic to the tubular epithelial cells, and they are very, very difficult to get rid of. So what would you see in the kidney who's got myoglobinuria? You would obviously see acute tubular injury, all the features I have just mentioned of acute tubular injury. But along with that, you will see this particular stringy material in the tubule lumina. And if you do a stain for myoglobin, an immunohistochemical stain for myoglobin, which obviously most labs will have, because obviously we look at tumors and stuff, we do myoglobin stain for diagnosing skeletal muscle tumors and stuff. So you will have myoglobin in the lab. So you do that lab, and all these stringy casts will just light up with the myoglobin. So the key diagnostic features will be acute tubular injury with these globular red-brown casts, stringy material in the tubules. This stringy material does have a very specific look. It is called beads on a string or a rope-like appearance, and they will be positive by immunohistochemistry for myoglobin. So that's what it will look like. You have got these tubules, which are obviously showing acute tubular injury, but it is not simple acute tubular injury, because within the tubular lumen, you can see they're filled with this bead-like structures, and in places forming strings or a wisp-like, like a garland-like structure. Quite a few of them look very wispy and ropey-like, and that is very typical appearance of a cast produced by myoglobin or acute tubular injury associated with myoglobinuria. There's one more thing to remember, that's not the only thing that causes cast like that. Sometimes deposition of hemoglobin, lots of hemoglobin, can also cause that kind of stringy material within the tubules. So what you do is you do a stain. You do a myoglobin stain and you do a Prussian blue stain. And whichever one it will be positive. Obviously, we've also got IHC for hemoglobin now, so you can do that too. So when you see this stringy material, the things that should come to your mind are either hemoglobin products or myoglobin. And obviously, doing immunohistochemistry and getting the right history is very important. That is a stain which is one of the cases I have had last year or year before last, where the patient actually had a history of a viral infection. I think it was COVID, and then also was on medication. So it had two things. And obviously, there's been reports that COVID has also caused very few reports of COVID causing myoglobinuria, but it's not definitely proven. But in this patient, he also had a history of statins intake. And you can see that the myoglobin casts have all lit up with the immunohistochemical stain for myoglobin. So that is acute tubular injury associated with myoglobin. One of the other things that very commonly we come across as in diagnostic renal pathology is light chain cast nephropathy. So what is light chain cast nephropathy? Patients with light chain cast nephropathy are patients who actually have got some kind of a paraproteinemia, most often multiple myeloma. It could be a patient who already has a diagnosis, or that might be the first presentation of the patient with multiple myeloma, which is not unheard of. So you can have occasionally patients who turn up in A&E with acute renal failure and have undiagnosed multiple myeloma. So patients with light chain cast nephropathy, generally middle-aged to older people with coming and presenting with acute kidney injury. They could have an overt myeloma at the time of diagnosis, as I've just said, and half of the patients with multiple myeloma and kidney disease have got light chain cast nephropathy. The thing about when the kidney gets involved with anything with paraproteinemia, the thing to remember is that the patient might not just have one pathology. They can have multiple pathologies. They can have AL amyloid associated with multiple myeloma. They can have MID or monoclonal immunoglobulin deposition disease, which is also related to paraproteinemia. They could actually also have a tubulointerstitial nephritis associated with it, but that is not because of the thing itself. It could be related to the fact that patients most of the time develop severe bone pain and then get NSAIDs, and NSAIDs cause TIN. So you can actually see that as a component too. But also there might be a chronic tubulointerstitial nephritis associated with light chain cast nephropathy. So when you're looking at a kidney, somebody who's got multiple myeloma, you need to look at every component and see whether there's something else happening. But if the patient has amyloid, the patient will be presenting slightly differently. Amyloid produces proteinuria, significant proteinuria, which is nephrotic range most of the time. So the presentation of the patient will be quite difficult, unlike light chain cast nephropathy, where the patient will be presenting with more acute kidney injury. So on light microscopy, what do we see? We see a sort of a chronic TIN in the background, and the tubules will have very specific casts, which we call fractured casts. And these casts, what again they do, the Benz-Jones proteins, they sort of are filtered through, they join with the TAM-Horsfall protein and form these very, very metachromatic casts within the tubular lumina. These casts are very toxic, and sometimes they can cause rupture of the tubule itself, and then can form a foreign body giant cell reaction. Immunofluorescence helps because unlike things which are polyclonal, because this disease comes with light chain restriction, so there'll be monoclonal staining of the casts by either kappa or the lambda chains on immunofluorescence microscopy. But sometimes it is difficult to see the clonal staining on just normal immunofluorescence. So in those cases, sometimes you can do formalin-fixed paraffin-embedded staining after pronase digestion. And that pronase digestion then unmasks the casts, the staining, and then you can see them. Electron microscopy, although it's very useful in most of kidney diseases, unfortunately not unfortunately, but in sort of tubulointerstitial diseases, it's not of much help unless it's something like light chain proximal tubulopathy. So electron microscopy not of much help in the sort of diagnosis. So as I just said, the etiology and pathogenesis of light chain cast nephropathy, it's a monoclonal light chain that is filtered through the glomerulus, which then forms a cast in the distal nephron by joining with the uromodulin or the TAM-Horsfall protein. And then these casts then elicit an inflammatory reaction, sometimes rupturing the tubules and forming giant cells. So key diagnostic features: fractured appearing casts, often metachromatic with syncytial giant cells, chronic TIN in the background, and immunofluorescence will show a clonal staining of the cast. Most of the time it is lambda, not kappa. So some pictures of light chain cast nephropathy. So you can see here that these are the big tubules dilated with casts, fracturing in places and almost filling the entire tubule lumen. Here you can see them again, fracturing in places, quite large casts, and then obviously there will be some acute tubular injury associated with it. Actually, if you look here, there is actually an oxalate crystal there too, but that doesn't mean anything in this context. Again, so another view of showing the large casts. On higher magnification in one area, if you see, when I said that it looks like these casts are fractured, because normal casts, normal TAM-Horsfall casts are not that hard, and they do not have these very hard edges. These casts are extremely toxic. So because they're very toxic, they actually damage the tubular epithelial cells so much that the tubular epithelial cells then fall off the tubular basement membrane and start sort of almost circle around the casts, like almost they are like stuck at the periphery of the casts, which is again something you don't see in normal casts. So that's another feature you can see. And sometimes when these casts rupture, they will cause a foreign body giant cell reaction with giant cells. Again, just a high power magnification to show that the tubular epithelial cells have desquamated from most of the tubular lining and are then forming almost like a garlanding around the cast itself. Another picture of the cast. And here is a cast where you can actually also see some neutrophils within it, which doesn't really mean much. So when you look at on immunofluorescence, we see that this is on the A is the lambda staining on immunofluorescence, and on the B is the kappa. And you can see that there is quite strong staining with lambda light chains, but hardly any staining with kappa. So there is light chain restriction. So normally where we work, almost every case, unless it's a pediatric case or a transplant biopsy, we get a kappa and lambda stain associated with all the other immunofluorescence, which is IgA, IgG, IgM, C3, and C1q, and a kappa and lambda. Pediatric cases, we don't get to do kappa and lambda because there's no, obviously they're not important, and transplant biopsies, we don't. So the next thing, still associated with the same sort of paraproteinemia, is what we call light chain proximal tubulopathy. Now, light chain proximal tubulopathy is slightly different. It is due to the accumulation of monotypic light chains within the proximal tubules, not distal tubules, in patients who have generally got more like an MGUS, which is not a sort of a fully blown myeloma, but monoclonal gammopathy of uncertain significance. Obviously, they can be seen in patients with multiple myeloma, but they are generally more commonly associated with MGUS. Light microscopy is quite different. In light microscopy, proximal tubules will show loss of brush border, which is very difficult to ascertain on H&E. It's more easier seen on PAS. And then you can see the sloughing of the tubular cells, along with sometimes frank acute tubular necrosis. But the important bit is to see that there's evidence of intratubular and intracellular crystalline inclusions. Sometimes non-crystalline, but most of the time crystalline inclusions. Now, they are not very easily seen on H&Es, but you can see them a lot better on PAS stains or trichrome stains. On immunofluorescence microscopy, again, the crystalline inclusion will show light chain restriction or monoclonal dominance, but in this type, there's predominantly kappa light chain and very rarely lambda light chain. Again, if you can't detect it by normal staining, you can do a pronase digestion on paraffin-embedded tissues. Unlike cast nephropathy, where it is not really, EM is not really very helpful, electron microscopy can be quite helpful in making a definite diagnosis because you will see these intracellular lysosomes, often which contain these inclusions, which you were seeing on PAS stain. These are like rod, rhomboid, needle, just irregular shaped electron dense crystalline material you will see within the tubular epithelial cells and sometimes within the tubular lumen. So you can actually, it can be quite helpful to make the diagnosis. Again, as I've said, that proximal tubulopathy is a disease which is caused by a subgroup of light chain, which is mainly kappa light chain. And it is mainly because it is produced in abundant, and then there is inadequate degradation of these light chains, which then get deposited within the proximal tubules. But unlike the casts you see in cast nephropathy, these light chains cannot join with or cannot make a proper cast with Kamhoff glycoprotein. And that's why you don't see those big casts. So the key diagnostic features will be proximal tubular injury with crystalline inclusions. There'll be monoclonal staining, typically a light chain restriction with kappa light chain, and you can do an EM to confirm the diagnosis. So just to show you here on this side, left side is a PAS stain, and you can see on the PAS stain here that there are some very crystalline looking material you can see within the proximal tubular epithelial cells. Compare it to this one and this one here. If you just notice on the ones, you can see them here. Not every tubule will have it, so you'll have to hunt for it if you're looking for it. And then if you just compare that with the immunofluorescence for kappa and lambda, you can actually see that's the kappa stain there and that's the lambda stain. And you can see this proximal rimming of the proximal tubular epithelial cells with kappa light chains, and lambda is negative. So based on all this, with the right history, you can sort of make a diagnosis of light chain proximal tubulopathy. It is relatively rarer and more, sometimes it's sort of underdiagnosed because you don't think of it because it's not as obvious as cast nephropathy. So if somebody is presenting with paraproteinemia and you cannot see much on straight away, look for something like this, which might be the cause for the kidney deterioration of kidney function. So that is ATN, and the two things I discussed there were myoglobin and light chains, because they are sort of the areas which are quite specific. So we'll go to another condition, which which we see not as often in routine, is oxalosis. Well, oxalosis is of two types, primary and secondary. Primary is the genetic type, where the patient has got a particular mutation and there is deposition of oxalate crystals, but not just in the renal tubules, but it will also be within the renal arteries. This is something which you don't see in secondary oxalosis. Now, secondary oxalosis can be due to certain conditions like malabsorption disorders, somebody suffering from chronic inflammatory bowel disease, and as I mentioned when I was starting in the talk, that ethylene glycol poisoning. Now, ethylene glycol or antifreeze, what we call poisoning, for some reason gets acute deposition of oxalate crystals within the tubule epithelial cell, and that is very, very acute. And you don't see it very often, but nowadays, but it used to be a lot more commonly seen around 10, 15 years ago. What do you see? You see fan-shaped birefringent crystals within the tubules. That's what they will look like under a polarizing microscope. And I'm sure all of you must have seen them, because anybody who's got chronic renal failure, you can see secondary oxalosis and a few oxalate crystals here and there deposited within the tubules. They're not enough to make a diagnosis of secondary oxalosis, but anybody who has got CRF can have few oxalate crystals here and there. So the next thing I will, because it's already been half an hour and I've only done 1/4 of the talk. So the other thing which we need to sort of get to see a lot in real life renal diagnostic pathology is acute tubulointerstitial nephritis. Now, acute interstitial nephritis commonly manifests as acute kidney injury, and with rapid decline in GFR, and the patient may have, not always, fever, eosinophilia, sort of mild hematuria, sterile pyuria, and proteinuria, which is not of nephrotic range. So they can present with a gamut of any of these symptoms. In some cases, history is quite good, because in some cases you will have the history that the patient has had medication or drugs. In some cases, there won't be. In some cases also, one of the commonest culprits, NSAIDs, which is non-steroidal anti-inflammatory drugs, can also induce minimal change disease type of injury with nephrotic range proteinuria, because we all know that there are a certain number of drugs which can cause minimal change disease within the kidney. One of them is NSAIDs. So you can actually see a combination of two things, because most of the time AIN will not produce nephrotic range proteinuria. In that case, it's important that you actually look at the EM and see how bad are the foot processes, whether there's effacement of the foot processes and the filtration slits on EM. So again, something which you have to remember, that the diagnosis doesn't always, it is a very clinical, kidney is a very clinical pathological area where you have to have the right history to make a diagnosis. AIN can occur at any age. AIN is recoverable in cases if the etiology is recognized and the ongoing exposure is taken away. So what do you see on light microscopy? There's a patchy edema and mononuclear cell inflammatory infiltrate, which are mostly T lymphocytes. You will see a variable number of plasma cells, some macrophages, and eosinophils. The typical picture, or the most diagnostic criteria for diagnosing tubulointerstitial nephritis, is the presence of tubulitis, which basically means that the lymphocytes or the inflammatory cells have infiltrated through the tubular epithelial cytoplasm and are sitting within the tubular epithelial cell itself. They can be associated with granulomas if the TIN is very severe and it causes rupture of the tubule itself. It can cause a non-necrotizing granulomatous inflammation, and you can see granulomatous TIN also. Immunofluorescence, nothing specific in terms of TIN, because it's not an immune complex driven or a complement driven disease. Electron microscopy, again, nothing much unless there's something happening. Either the patient has got minimal change or membranous or something that's different, but otherwise nothing significant. So acute interstitial nephritis diagnostic features, there will be interstitial edema. There'll be an interstitial lymphocytic infiltrate with occasional plasma cells and variable eosinophils. You will see variable amount of tubulitis associated with acute tubular injury. And in some cases, you might see non-necrotizing granulomas. This is a picture of somebody who is, I think, related to NSAIDs. And you can actually see, even on low magnification, you can see that there is significant amount of interstitial inflammatory infiltrate. Eosinophils are quite abundant in this one, and you can see them quite clearly with these pink blobs of neutrophils around, eosinophils around, and you can actually also see tubulitis, where you can see lymphocytes infiltrating through the tubular epithelial cells. Again, another picture where you can see eosinophils scattered around. This patient also has some chronic damage for whatever reason. If this is an elderly person, they will have a significant amount of chronic damage in the biopsy. And you can see that that tubule there is completely taken over by the lymphocytes. And you can see an occasional lymphocyte sticking around here. You can see a few lymphocytes sticking around here. And so you have got tubulitis basically in some of the tubules. Another area where you can again see this is probably a bit more sort of long-standing, and you can see there is some tubulitis here, but there's a lot more interstitial inflammatory infiltrate. So without the presence of tubulitis, you cannot make a diagnosis of TIN, because interstitial inflammation can be part of loads and loads of glomerular diseases, vasculitis disease, or anything. So you need to see the tubulitis to make the diagnosis. Again, you can see it quite clearly here that these lymphocytes are sticking around and entering the tubular epithelial cells. Here, actually, it's very difficult, but you can see that there is a big tubule there which has been completely taken over. And there's another one here. And you can see in here, there's another one here. So you will see scattered, and still you can see a few eosinophils sticking around. Another one, I think I'm going to just go ahead, because otherwise, again, that's another tubule there showing it. And there's a lot again of eosinophils and some tubulitis there. This one, I'm showing you a picture to show you that the whole tubular epithelial cell, the tubule is completely being eaten up by the lymphocytes. And at one point, this would rupture and form a granuloma here. And that's when you sort of start seeing granulomas in TIN. Okay. So drug-related acute TIN is one of the commonest forms of TIN we see, but that's not the only form of interstitial nephritis. It can occur as a result of antitubular basement membrane antibodies, diagnosed as linear tubular basement membrane disease. And in that case, you will see staining of the tubular basement membrane, very linear staining with anti-IgG antibodies. You can also see tubular basement membrane immune complexes with granular tubular basement membrane staining on immunofluorescence microscopy. There are certain infections, like some viral infections, some fungal infections, obviously tuberculosis, in which you will see necrotizing granulomas, fungal infections sometimes, which again you will see granulomas. And in those cases, you will have to sort of think of them and do either, well, obviously you'll have to send a sample for culture, and certain things you can look up on like for PS and GROCOT and acid-fast bacilli, you can pick up on special stains. Obviously, there's another condition which we know of, which is called TINU, which is tubulointerstitial nephritis with uveitis. And then these patients present both with uveitis, meaning that obviously they'll be going to the ophthalmologist with uveitis, and then on a urine dipstick they will be found that they have got non-nephrotic proteinuria or hematuria, and then they will have this condition called TINU. So again, something to bear in mind about it. Obviously, you can get a lot of inflammation within the kidney, as I've just mentioned, in certain necrotizing glomerulonephritis or vasculitis. And if you do not have glomeruli in the biopsy, and if the biopsy is inadequate, you can actually misdiagnose something which is vasculitis as TIN. So it's important that the biopsy has to be adequate. You have to see the glomeruli to make sure there's no glomerular disease. Non-necrotizing granuloma is obviously a systemic condition, sarcoidosis, in which you can see well-defined confluent, and I'm not going to go much on it because it is the same wherever you see sarcoidosis, whether it is in the kidney or whether it is in the skin or whether it is in the lung, the morphology looks the same. So granulomatous tubulointerstitial nephritis, again, two types, necrotizing, as I've said, mostly with an infective etiology such as tuberculosis or fungal infections, and non-necrotizing ones, which could be either related to sarcoidosis or drug-induced TIN. So here you've got sarcoidosis, large interstitial, they just separate the tubules. They don't damage the tubules, they just separate the tubules, make space for themselves, and they have well-formed granulomas with multinucleated giant cells along with calcification, as you would see in any patient who's got sarcoidosis. So something which I'm bringing into along with where I'm talking about the typical TIN is IgG4 related tubular interstitial nephritis, something which in the last 10 years has become is a diagnosis in the last 10 to 15 years. So IgG4 related disease is an immune mediated systemic condition and that normally just doesn't involve just the kidney. It is a systemic condition, so it presents with multiple discrete tumor-like lesions, which can be infiltrating numerous organs. And they are generally composed of lymphoproliferative infiltrates associated with large numbers of IgG4 producing plasma cells and associated with a very typical form of fibrosis called storiform fibrosis. Normally, serology is very helpful because the patients will have high serum IgG4 levels, more than 135 milligram per deciliter, and this is something you will see in more than 2/3, not all, but more than 2/3 of the patients. More commonly involves middle-aged men, and 60 to 90% of patients will actually have other multiple organs or sites involved by the disease. And as I said, there are a lot of organs which can be involved: pancreas, the pancreatic biliary tract, salivary glands, lacrimal glands, retroorbital, retroperitoneal, and obviously kidneys. Obviously, these patients also present with lymphadenopathy, and 40% of these patients will have some history of either an allergic, underlying allergic condition or an asthmatic condition, and some of them will also have peripheral eosinophilia. So kidney involvement, that's because that's what we are concentrating on today, is the kidney involvement or IgG4 related kidney disease can occur in the form of either tubulointerstitial nephritis. Some patients, that's the commonest form. In some people, they can develop membranous nephropathy, and in some patients, you can have pyelitis. So depending on what the disease is, obviously the symptom will be, the symptomatology will be different. The disease is quite indolent, and patients may be asymptomatic sometimes, but patients also may present with proteinuria, hematuria, and they can have decreased kidney function. Also, to remember is they do present with low complement levels, predominantly C3 and C4 in almost half the patients. If the patient has got membranous nephropathy associated with IgG4 related disease, the patient will obviously have nephrotic range proteinuria. So thing to remember again. On imaging, multiple bilateral tumor-like lesions will be seen within the kidney, and there obviously will be, because the patient can present with pyelitis, thickening of the pelvis wall. So what do we see in light microscopy? It is a TIN for that matter. There is a tubulointerstitial nephritis, but the main inflammatory infiltrate will be predominantly plasma cells. Obviously, you can see plasma cells in any TIN. So if you're seeing a very, very high number of plasma cells in the TIN you are seeing, I think we don't normally do IgG4 as a routine practice on our in routine diagnostic, but if I am seeing a lot of plasma cells, I will ask for I will go and ask for an IgG4 stain on the kidney biopsy. So in cases where we are trying to diagnose somebody with IgG4 related TIN, there should be more than 10 IgG4 positive plasma cells per high power field, or more than 40% of the cells which you're seeing, the ratio of IgG4 to IgG plasma cells should be more than 40%. Along with this, you will also see interstitial fibrosis, which has a very typical storiform pattern, which is like swirling fibrosis. We use the storiform pattern here, but obviously we use it in other things, like when you're diagnosing a DFSP in a skin biopsy or a soft tissue, you would dermatofibrosarcoma protuberans, that kind of fibrosis, which you see storiform fibrosis. So you will see the swirling fibrosis with fibroblasts, like the spokes of a cartwheel. And that, together with the large number of, or the diagnostic number of plasma cells, you can start thinking about IgG4-related TIN. Obviously, it's a clinical pathological diagnosis. Another type of fibrosis which you see in patients with IgG4-related TIN is called bird's eye fibrosis. So you do get the storiform fibrosis, but you also get another type of fibrosis called bird's eye fibrosis, which is characterized by every single inflammatory cell will be surrounded by a collagen fiber, like forming a nest around every single inflammatory cell. This is better seen on either silver stains, on PAS, is more difficult on H&E stains. Obviously, because of all the fibrosis, you will have associated tubular atrophy in the fibrotic areas. The margin between affected area and unaffected area is relatively quite well demarcated, but you might not have it in your biopsy. So that is not really something you would be able to see in a small kidney biopsy. And obviously, you can see obliterative phlebitis. What do you see on immunofluorescence? So you can see granular tubular basement membrane immune deposits for IgG4 predominantly, but sometimes with a little bit of IgG1 and IgG3, but predominantly IgG4. And sometimes you can also see C3 and C1q, but the diagnostic thing is that you need to see IgG4 deposits. These deposits are generally not seen all over the place. They will only be seen mainly in the areas where the inflammation predominates. If the patient has also got membranous nephropathy associated with IgG4 related disease, in those cases, obviously you will see changes in the glomeruli with thickening of the capillary loops, membranous staining with IgG, but not always IgG4, and they will not stain for PLA2R. PLA2R, obviously, we do for all membranous, because the de novo membranous now, the patients have got PLA2R antibodies. So this can be done serologically also, and can be done on immunohistochemistry. In my department, we yet don't have the PLA2R, so we do it serologically only. So electron microscopy, immune type tubular basement membrane deposits will be seen, which you will be in keeping with what you were seeing on immunofluorescence. And if the patient has membranous nephropathy, obviously you will see large numbers of subepithelial deposits. Key diagnostic features: TIN with abundant IgG4 plasma cells, storiform fibrosis, and presence of tubular basement membrane immune deposits. The thing to remember is that there are certain conditions which come into the differential diagnosis, but the most important one is people who have got ANCA-associated vasculitis, or EGPA, which is eosinophilic granulomatosis with polyangiitis. In those patients, they will not just have increased plasma cells, but they have a very significant number of increased IgG4 plasma cells. So even if you did the stain for IgG4, there'll be a huge number of IgG4 plasma cells in the component there. The thing to remember is that the patient has got ANCA-associated vasculitis, so you will be seeing the changes or segmental fibrinoid necrosis and changes of vasculitis within the glomeruli. So again, if there are no glomeruli in the biopsy, you could misdiagnose it as something completely different. So it's very important to have an adequate renal biopsy to make a diagnosis. About 15% of TINs can have a small number of IgG4 positive plasma cells, but you have to have a certain number. There are a lot of other conditions which we are not going to in detail, but you have to remember that in mind. So what do you see? So that on the side, you can see that this is a tubulointerstitial, this is a silver stain on this side, and that is a PA stain. And you can see when I was talking about bird's eye fibrosis, that you can see individual plasma cells can sometimes have fibrosis around them. And same goes here. And here it's a bit more storiform, but also around one or two sort of cells circulating fibrosis around it. So if you see that, along with, obviously this is quite severe fibrosis, the patient has got quite bad, like almost end-stage kidney there, but you can see this is the IgG4 staining, and you can see the predominant number of plasma cells staining by IgG4 plasma cells. So that is IgG4-related tubulointerstitial disease. The other thing which we come across, particularly, but in this part of the world, polyomavirus nephropathy is generally mostly seen in transplant biopsy. We automatically do a BK virus or a polyomavirus stain on every transplant biopsy to make sure that we are not missing it. So polyomavirus infection occurs in mainly transplant allograft kidney and in native kidneys of immunosuppressed patients. Obviously, it is related to BK virus in 80% and JC virus in 10 to 20%, and the SV40 in a few cases. Transplant kidneys, almost 5% of transplanted kidneys could have polyomavirus in them, and patient generally presents with asymptomatic, can be asymptomatic or can have acute or slowly deteriorating renal function. Okay, so light microscopy with polyomavirus infection, patchy pleomorphic interstitial inflammatory infiltrate, will be lymphocytes, plasma cells, could be a few neutrophils. You will see tubulitis in there, so don't jump. If it's a transplant biopsy, don't jump into the diagnosis of making a diagnosis of rejection unless you have seen. Obviously, history is important because serology of these patients, the clinician will tell you that this patient has got positive serology for polyomavirus. So, but you will see tubulitis in patients who have got BK virus or polyomavirus nephropathy. The infected tubular epithelial cells, because that's what are mainly affect. Unlike CMV, which infects the endothelial cells, BK virus mainly affects the tubular epithelial cells. They will have enlarged nuclei with large amorphous inclusions. These inclusions have a very ground glass appearance, and sometimes with central, in the older ones, you can get central clearing and a vesicular appearance. The distal tubules are generally more involved than the proximal tubules, and you will see positive immunohistochemical staining. We have immunohistochemistry for BK virus for the nuclei that are involved with it. Immunofluorescence will not be much apart from the fact that you could have some tubular basement membrane staining for certain immunoglobulins, but otherwise nothing. And on electron microscopy, you will be able to see the particles. We rarely do EM on them. We don't really need to. So the key diagnostic feature will be a pleomorphic interstitial infiltrate. There will be viral cytopathic changes within the tubular epithelial cells. And obviously, there'll be nuclear staining for BK-SV40 staining. So that is what it looks like. You can see there are two pictures here. This is a slightly lower mag where you can see that there is a bit of acute tubular injury. Obviously, you can see there's also a bit of tubulitis if you notice. There is some tubule epithelial cells where there are lymphocytes. And along with that, you've got these large nuclei which have a ground glass appearance with some of them showing sort of slightly darker center. And in this one, you can see the large pseudo-inclusion or amorphous appearance of the nucleus, which has got the BK virus in it. If you look at this is a more later stage where the BK virus has been in the kidney for a while, and instead of having that very hyperchromatic vesicular appearance, you get this very nuclear clearing of the tubular nuclei, and you can see they look almost empty. That's in the later stages of BK virus staining, and that is a nuclear stain for BK virus and just picks out the cells which are infected or the nuclei which are infected by the polyomavirus. Along with that, I just thought I'll mention a condition called karyomegalyc nephropathy. Now, karyomegalyc nephropathy is not an infection. It is a rare autosomal recessive disease due to the mutation in FAN1 gene, and it presents with low-grade proteinuria and slowly progressive loss of GFR. Generally, it's a disease that occurs in the 3rd to 4th decades of life and can end up in end-stage kidney disease. So light microscopy, you will have these bizarre enlarged proximal tubular nuclei with interstitial fibrosis and tubular atrophy, and the glomeruli don't tend to be involved in it. Immunofluorescence is not useful, and again, EM is not useful. As I've said, it is something to remember. We get one or two cases a year sometimes, or one case a year. It's pretty rare, but if you do not know about it, you will miss it. Differential diagnosis, anything which causes enlargement of the tubular nuclei. Sometimes certain poisons can cause it, certain viruses can cause it, and as I've just mentioned, polyomavirus, cytomegalovirus, CMV staining, it's, as I said, CMV generally predominantly involves the endothelial cells, can involve the tubular epithelial cell also. So that is two pictures here, and you can see that obviously there is no inflammation because it's not an infection of any kind. It's just that some of the nuclei will look very large and hyperchromatic scattered around the tubular epithelial cells. And you can see them again here associated with nerve. Obviously, this is a diagnosis which is made with genetics, with doing this, the mutational analysis for the patient. Just to mention a couple more things. One is sickle cell nephropathy, because sickle cell nephropathy obviously is relatively more uncommon in this part of the world. But it involves both the glomeruli and the tubules. So light microscopy, sometimes you can get, obviously the important bit is if the patient is presenting in sickle cell crisis, you will have occlusion of the arteries and causing cortical infarcts. But in patients who have got long-standing sickle cell nephropathy, you see glomerulomegaly, which means that the glomeruli look relatively enlarged, and there'll be global and segmental FSGS type picture, focal segmental glomerulosclerosis, which is predominantly perihilar. And sometimes you can also get to see collapsing glomerulopathy type of picture due to ischemia. But the thing why I put it here is because apart from these things which you will see, you also have problems in the tubular epithelial cells. Because of the large amounts of hemosiderin deposition, there might be quite extensive tubular damage. So you can see reddish granules in the tubular epithelial cells, which will stain positive, obviously, on Prussian blue stain. And you can occasionally see deposition in the epithelial cells, but predominantly in the tubular epithelial cells. You can sometimes see sickled red blood cells in the medullary peritubular areas, and rarely in the glomeruli. EM is not contributory, and neither is immunofluorescence. So the only reason I put it here is because of the fact that apart from the changes which you see within the glomeruli, you can see a lot of changes within the tubular epithelial cells. Again, so that's the picture you can see here. On this side, I have put a picture of a large glomerulus here, and then this particular area, you can see there's a segmental sclerotic lesion or like an FSGS type of lesion there. And on this side, you can see there's an H&E where all the tubules epithelial cells are looking very brown. When you do a Prussian blue stain, they are full of hemosiderin. And I think the last thing I will talk about is just something which we see more often now is cyclosporin toxicity. This can be seen, this is predominantly seen in the context of, again, transplant patients or people who have been transplanted. You get toxicity related to that. But you can also see them because it's a drug sometimes given to patients. Calcium inhibitors can be given to people who who have got minimal chain disease and nephrotic and are nephrotic. So sometimes in native kidney biopsies also you can see cyclosporin toxicity. So you can have acute tubular toxicity where it is similar to the functional toxicity but a lot more severe. And the damage in acute toxicity predominantly is in the tubules, and you will have dilated endoplasmic reticulum and giant mitochondria with lysosomes and microcalcification. And what it manifests is the isometric vacuolation of the tubules, which I will show you a picture of. Sometimes with acute cyclosporin toxicity, you can also see smooth muscle degeneration, almost lysis of the muscle wall of the arterioles and the medium size or the small size artery. And later stages, these areas become hyalinized, and you can sometimes see quite significant narrowing and presence of mucoid deposits. But it is dose-dependent cyclosporin toxicity and sometimes reversible, not all the time, but sometimes reversible. So just to show you a last picture where you can see that this is actually not a transplant patient. This is a child who had nephrotic range proteinuria and had minimal chain, presented like minimal chain disease. Well, patient had minimal chain disease, was given medication and was not recovering, developed acute kidney dysfunction. And that's what every single tubule had, this very, very sort of foamy, frothy appearance, which we call isometric vacuolation of the tubular epithelial cells. So that is something you would see in acute cyclosporin toxicity. I think I've just about managed, rushing to finish the entire talk. Thank you. If there are any questions.
Well, thank you very much, Anu. That was a fantastic run through. And I think it's an area that we don't really get a lot of teaching on. So I think you're absolutely right. When people talk about renal disease, there are lots of talks about glomerular disease and so on, the basis of that and electron microscopy. But I think your run through, which is incredibly comprehensive, of all the different tubulointerstitial diseases. I mean, in your experience, what's the most common thing a renal pathologist sees? Is it tubular disease, or is it or tubulointerstitial disease, or glomerular disease?
Actually, glomerular disease still is quite common, but the problem with it is that tubulointerstitial diseases are sometimes overlooked. And but TIN, the two things which we see very regularly in our practice is TIN, tubulointerstitial nephritis, acute tubular injury, because a lot of transplant patients, the patient will have kidney dysfunction and will come and they say, oh, he's got rejection. They don't have rejection. There's just that they've got primary kidney dysfunction and I've got acute tubular injury. And also, we do see a lot of, because the cohort of the people who the biopsy for elderly people, we do see a lot of light chain cast nephropathy and tubulointerstitial related to that. It is not uncommon. And in the last year, actually, every single case I've shown is actually from my this year's diagnostic workload. None of these cases are from any sort of hi-fi things, They're all the cases which I've had. I've had a sickle cell nephropathy recently, and these all patients are real life patients, which I've had in the last 12 months.
And just asking the audience, if anyone's able to raise their hands, how many people see sickle cell nephropathy, for instance? I guess if you don't think of it, you might miss it in a biopsy.
Yeah, absolutely. You would miss it in a biopsy.
So I think it's I don't know if anyone's got any questions or comments. You have to raise your hands as you're in the webinar, and then Emily will let you in, or not.
I think it's a disease which sometimes I think it's a topic where if you don't know a lot about it, I think this was quite good. I think they will be able to read through and listen to the talk again,
so
and they can take it all in. Yeah,
it's been recorded and we'll upload it.
IgG4 related disease is becoming more and more. I have seen it last year in a child. Actually, it was a Chinese boy, 11-year-old boy who had IgG4 related disease.
And why do you think it's becoming more common?
I don't know whether it's becoming more common or we are diagnosing it more. I
Yeah.
think we are diagnosing it more. It has, I think, been around. I just think we are more aware of the disease. I think some of them were just put down as tubulointerstitial nephritis and not thought of,
Okay.
you know.
Yeah.
And the reason I talked about it today in detail is because there was a case recently, around 6 months ago. The patient had EGPA, choke Strauss, and there were no glomeruli in the biopsy. And it looked like it was full of IgG4 positive cells. And I almost ended up saying, oh, could it be TI? And then when I talked to the clinician, I came to know, well, the patient actually has got a vasculitic disease, and we just don't have glomeruli in the biopsy. So saved you from just talking to the clinician and getting the right information, sort of saved a lot of hassle.
Yeah. Okay. Well, there aren't any questions from the audience. I know you're very busy, Anu.
Question
Oh, no, there is.
in the Q&A.
Yep. So I'll read it out then. Let's see. What resources would you recommend trainees, especially if they work in a district general hospital with no medical renals? So how would they go about seeing material?
Well, I mean, if they have access to anything on the internet, like the Leeds website, the Leeds internet website has got sort of by topics. They've got on the internet. Or another thing is that the American Journal of Kidney Disease Pathology is an internet resource where you have got sort of disease-wise. If you go on it disease-wise, you can go through on the internet, and there are very nice pictures of it too. On it. So I think looking at on the Leeds website for it, and also looking on the American Journal of Kidney Disease Pathology website is quite good for training.
Okay. Any other questions? No? Well, in that case, thank you very much, Anu, for your continued support.
Thank you very much for giving me the opportunity.
Yeah, no, it's all our pleasure and our honor to have you. So thank you very much.
Okay.
Yeah, Anu, take care. Yeah. So for the